This October, the American Society of Anesthesiologists is coming together in a city rich in U.S. history and culture, Philadelphia. I'd like to personally invite you as a member of the Indian College of Anesthesiologists to join us at Anesthesiology 2024. Connect with more than 10,000 anesthesiology professionals from all over the world as we explore clinical innovations, build stronger bonds, and address the issues facing our specialty today. I hope you'll be a part of it. Learn more at asahq.org/annual meetings.
Today is our fourth annual. We had been conducting quality collaborative webinars for the last 4 years without any interruption. And we were really receiving accolades from all over the country as well as outside. We discussed on current topics and areas which is absolutely necessary for the examination going students, as well as occasionally fundamentals where we think we had to give a deep routing to our industries. Well, my friends and colleagues, today in this fourth annual, we are bringing a different set of presentations. It's a compendium of presentations of the developments or the sense of thought, what is prevailing at the national level as well as in the global level regarding anesthesia practice. And it's being done by all the major stakeholders of Indian College. Dr. Mukul Kapoor, Dr. Kumar Belani, Dr. Muralidhar Kanchi, Dr. Baljit Singh, Dr. Jayashree, and myself are coming out with presentation. First person to talk is Dr. Mukul Kapoor. Mukul Kapoor is our editor of Yearbook of Anesthesiology, and is an ex-brigadier of Indian Army, and is currently the head of the department at Amrita Institute at Faridabad, Delhi.
Thank you very much, sir, for the wonderful introduction and a very kind words you've said. And we start this very interesting webinar talking about technology and how it's going to change clinical anesthesia in the near future and what things are in the offing. So I'll try to enumerate the technologies which are coming into different aspects of anesthesia. I'm not going to go into details of the technologies, but I'll just enumerate them. So to introduce this subject, I would like to add that healthcare is undergoing a sea change, and particularly a sea change because of the technology taking over healthcare in a big way. Technology is getting into various invasive and less invasive modalities to detect and diagnose disease, to monitor disease, and thereafter to treat it also. And I may say this in premature obituary to the stethoscope, but the stethoscope is dying a slow death, and though it has been a trusted companion of doctors and particularly anesthesiologists, stethoscope is unfortunately dying a death, and we have to pay an obituary to it. And I remember when we were young, we could not move out as anesthesiologists without a stethoscope hanging from our neck. But today things are changing. We are moving without the stethoscope around our neck. And that is because of the fact that very good imaging and sound technologies have taken over the role of the stethoscope, and they are permitting better diagnosis as compared to the stethoscope. We went into the next thing I will talk about is the monitoring of the oxygen saturation. We went into oximetry a few decades ago actually, and we thought that was one of the best things to happen. But what has happened is over the years, pulse oximetry has changed and has donned multiple new roles, which includes pulse pressure variation measurements, peripheral arterial resistance measurement, and now you can also diagnose and detect the cardiac output of patient with the help of pulse oximeters. So pulse plethysmograph has come forward in a big way. But what is more important is the new technology, which is gradually taking over the role of pulse oximetry, and that is near infrared spectroscopy, which is NIRS, which is actually measuring the cerebral oxygenation, which probably is the ultimate goal, which all anesthesiologists have ensured that oxygen reaches the brain. So now that is taking over from the pulse oximeter, and maybe after a few years, it'll become the essential monitor rather than the pulse oximeter alone. Similarly, echocardiography or electrocardiography have been the mainstay in monitoring patients. And electrocardiography, particularly the ECG, we have been monitoring, and you can't do today a case without an ECG monitor along with you. But how are things changing here? ECG is also changing because now ECG is getting more into wireless stages. So instead of putting wires on the patient, we are going into wireless telemetry based ECG. And why it is going to change things is that because we can continue to monitor the ECG in the post-operative period, because that is when lots of complications occur. So you can leave the ECG electrodes on the patient, and with the help of remote monitoring, we can detect pulse post-operative complications much earlier. So this is something which which is coming into technology. Then predicting the difficult airway. This has always been a problem. Despite all different classifications like Malampatti, etc., we have developed multiple classifications, developed multiple algorithms for managing the difficult airway. Difficult airway still remains a problem. Even today, we have a lot of morbidity because of difficult airway. And the problem is, despite development of multiple algorithms, multiple diagnostic procedures, we are still finding it difficult to diagnose preoperatively a difficult airway. So this is where AI is coming in. And now with the help of AI, what you can do is you take a photograph of the patient from different angles, and with the using the AI algorithms and calculating the various distances which are there on the face of the patient, calculating the various distances between different structures on the photograph, the AI is able to predict the Comac-Lehane view much better than any other system which was available, whether it was Malampatti or any other system. So AI has come into a big way into predicting difficult airway. And so we are mentally prepared rather than we get a surprise on the table. What the AI does is uses convolutional neural networks to diagnose it. It takes in a lot of data, and from the data, it tries to calculate different things and bring out the actual complexity of the airway. The next thing which is likely to come in a big way again in the near future is depth of anesthesia monitoring. Depth of anesthesia monitoring has eluded us for quite some time. We have tried various aspects. We have been looking at EEGs, we have been looking at BIS, and we have been looking at mean arterial pressure specificity and auditory evoked potential. So many things we have been looking at, but none of them has achieved the accuracy which we need. They have to, at the best, gone to about in the 80s as far as percentage of detection of depth is concerned, but we still have the problem of awareness in patients. So we have to get out of this problem of deciding how deep our patient should be. And again, it's AI which has come in a big way. AI is being used today to integrate the findings of the mean arterial pressure and the findings of the BIS. And in that integration of the finding of this together is helping us predict future outcomes and future changes as far as the awareness is concerned. So this is coming in a big way. And very soon we'll have lots of monitors which have got integrated BIS along with mean arterial pressure. And they'll be able to predict anesthesia events much better than what BIS does. And how this does it, again, in the same way with this sample entropy, etc., and using various EEG signals which are processed. Thereafter, they go into the autoencoder, and thereafter it gives the actual result and helps us in increasing the depth of a patient or decreasing the depth and deciding whether the patient will have awareness or not. Then we also have control over the anesthesia delivery. Now, anesthesia delivery systems, I'm sure many of you are using today. As far as the delivery system in the anesthesia machine is concerned, we already have that kind of AI in which we can put a target control as far as the depth is concerned, as far as the MAC is concerned, and the machine on its own changes the concentration of the inhalational anesthetic, the gas flows, etc., so as to keep the patient at a particular target MAC. But what is coming now is something different. What is coming is AI is going to correlate the drug concentrations and capture the response of the patient to a drug, and thereafter calculate what is going to be the requirement of infusion of the particular drug. Supposing you're giving an infusion of propofol, it is going to calculate on its own what is the dose required, because every patient is different. The volume of distribution of a drug is different in every patient. So every patient is different. So to overcome this problem, AI is going to calculate the depth based on the response of the patient, and thereafter help you give the patient further treatment. How does this happen? Again, this is happening because the AI is looking at the BIS, it is looking at the blood arterial pressures, it is looking at the infusion rates, it's looking at how much initial bolus you had given, and based on all that, it calculates, and then it will give the correct rate of infusion of that particular drug. So this is going to come in a big way for multiple drugs like dexmedetomidine, propofol, anything which is used IV, and maybe even infusions of remifentanil, which is going to be more often used now. Then we have monitors which are able to predict events. Now the monitors will be able to predict what is going to be the hypnotic effect based on the inputs it gets from the BIS monitor. Then it can predict the return of consciousness after general anesthesia. It can predict rate of recovery after neuromuscular blockade, degree of hypotension which is likely to occur after you have given general anesthesia or spinal anesthesia. The monitor can also predict the degree of airway difficulty and respiratory depression during conscious sedation. So all these event prediction monitors are coming in. We already have one event prediction monitor, which is called the hypotension prediction index, which has been brought out by Edwards. And this particular one, which is called as Acumen IQ. Acumen IQ gives you information that this patient is likely to have hypotension 15 minutes after this. So you start taking action now. So based on various parameters which the Acumen picks up from the monitor, it is able to predict a subsequent hypotension. So this is already in, HPI is already in. Other things are also going to come in very soon. Of course, another thing which is coming in is AI in ultrasound guidance. And with ultrasound guidance, you feed in a lot of data about images of different structures into the ultrasound machine. That's all fed in. And based on the machine, it keeps guiding the person who is giving the ultrasound block into how and where to approach. The AI identifies the artery, the nerve, and the vein. Everything is identified, and based on that, it guides you. The AI actually guides you to the correct place and says, now you are at the right place. You are at, it also decides the acoustic window which is required, and also helps in even telling you whether the vertebral level, in case you're using ultrasound for giving a spinal or an epidural, it will even identify the vertebral level which is at which you are entering. So this is again, this technology is very advanced today, and it's going to come in again in a big way. Then you come to post-operative analgesia. Post-operative analgesia is moving away from normal PCAs to Wi-Fi enabled PCAs. So everything is going on to Wi-Fi. It's remote control. So a physician sitting at his home can control the PCA pump, which is there with the patient. And you can do a remote monitoring. You can put in intelligent alarms into the PCA. It can assess the pain as well as tell you. So it's basically working on a wireless environment with a central server managing the Wi-Fi analgesia pump, and it is receiving all the inputs and from the terminals which are attached to the patient. So you have AI PCA, which is so it's an AI assisted PCA, and so we are moving from salvage analgesia to preventive analgesia. So this is how it is going to work. It's going to prevent the patient from having pain. So before the patient has, in a PCA, the patient has pain and then triggers off a bolus. While here, it's going to give a preventive act. It will do preventive action in giving the analgesic much before the actual pain occurs. Though this is there. There are some ethical and safety concerns with the use of these devices, but I'm sure they will overcome these ethical concerns and safety concerns also. Now, next we come to post-operative cognitive dysfunction. This is one thing which is highly recognized today because we are doing more and more patients who are aging, and it's a common complication again today. More and more aging patients are being done, more and more frail patients are being done, and they are the patients who are prone to post-operative cognitive dysfunction. And this is prolonging hospital stays, causing new complications, and increasing medical expenses and length of stay in the hospital. So we have to overcome this problem also. So AI is coming to this also. Now AI is coming into this, and in what they're doing is now BIS control is going into AI. The AI controls the BIS level of the patient. And there are some studies which have shown that when AI controls the BIS levels of a patient, in the post-operative period, patients tend to have lesser anxiety, they are less tired, they have lesser concerns of breathing difficulty in the post-operative, and of course, it reduces the length of stay. So all this also contributes, all these things, if they are more, they contribute to post-operative cognitive dysfunction. So post-operative cognitive dysfunction becomes less with the use of these kind of monitors. Of course, operating room logistics, these are very important in today's world. The number of surgeries being done in every OT is increasing by the day, and we have to adjust more and more cases. We have to have an OT environment which is much, much more efficient than what it used to be. And because today, in an OT which used to handle about 10 cases a day, today it's handling 40 to 50 cases a day. And unless we improve the logistics of the OT, we cannot do that. So AI is coming to that, and this also. And AI is able to do a more precise scheduling of the OT time because it can track movements and actions of anesthesiologists. It can limit wastages of resources and staff wastage also. And it can actually calculate OR use per procedure and per staff. Every staff takes different kind of time. Some staff are slow, some are fast. So based on every staff, it can calculate the requirement of OT time. It can coordinate with PACU and the OR simultaneously. It can limit cancellations and even calculate the time duration for a specific surgeon. Some surgeons are slow, some are fast. So AI can help you calculate that also. And the neural network, which is there in the AI, actually help you predict and post cases correctly and in a much better fashion. Then, of course, this is already there again in use, the use of Kepler intubation systems. Intubation is coming in a big way. We started using the video laryngoscope. But today what has happened is the video laryngoscopy is being assisted by the robot, and the Kepler intubation system is already in place. It's being used. It's a little expensive as on date, so it's not become not in common use today. But very soon you'll have the Kepler and or clones of the Kepler system, which is being used by everybody. So we'll have robotic intubation very soon as a common measure in all operating rooms. And finally, we have the sedation monitors that we have the McSleepy IV sedation machine, which is also called as the anesthesia robot. And this machine is you can mount it's for different ways. These are some samples of the McSleepy anesthesia robot, which are in some parts of the world. They are capable of monitoring and giving the correct amount of medication for keeping the patient sedated, ensuring unconsciousness, ensuring muscle relaxation, and also ensuring that the patient does not have pain. And based on this machine is based on heart rate and blood pressure measurement, and it can do all this. So all this is the capability of the McSleepy IV sedation machine, which is again going to be in common use. So where are we today? Today we are at this, when you talk about the Gartner hype cycle, which is commonly used in all management classes. Today we are here at the tip where we have a lot of inflated expectations from AI, and you may have a trough of disillusionment soon, but very soon there'll be a scope of enlightenment, and our productivity is going to increase. Though today no machines are prescriptive, and there are predictive algorithms, but you do not have actually machines doing the actual thing. But very soon You'll have commercial machines which are available, which will not only predict, but may also help us in delivering the same thing. And so it's not a very thing which is very far off. And because of all this happening, anesthesiology, the journal of the ASA brought out this cover picture of one of its issue, in which they said that robotic anesthesia will be available soon. This was in 2020. I'm sure by the time it's 2030, we'll have robots delivering anesthesia. And so this may be the scene in an operating room, that a robot is at the head end and the patient is lying down. And you may have a different kind of situation, and you'll be controlling the robot. Just like today, the robot is being controlled by the surgeon to do robotic surgery. We will not be left without a job. We'll definitely be with a job, but this robot will be controlled by us and will not be autonomous in any way. Thank you very much.
Thank you, Mukul. Friends, you heard about the advancements which are taking place. Well, we hope within another 10-15 years' time, the practice of anesthesia will be different. And with that note, we move on to the next by Dr. Kumar Belani. Kumar Belani is our overseas dean, and he is practicing at Minneapolis, and he'll be talking to you from there. And he is talking on safety and anesthesia, one thing which is real, a challenging word all over the world, and where we have to be more careful, whether it is a machine administering anesthesia or patient administering anesthesia. Over to you, Dr. Kumar.
Good evening. My name is Dr. Kumar Belani, and I'm talking to you from Minneapolis, Minnesota, USA. Sorry, it's evening over there, so good evening to you all. I will be speaking on enhancing anesthesia safety, insights from the Anesthesia Patient Safety Foundation, also known as APSF, and I will also say a few words on QI, Quality Implementation Initiatives for Anesthesia Programs. This is a proposal for the Indian College of Anesthesiologists. So APSF is a non-profit organization that was founded in 1985, and its mission is to ensure that no patient is harmed by anesthesia. Like I said, the mission is to improve patient safety during anesthesia care, and the vision of APSF is that there should be a world where anesthesia care is safe for every patient. So I guess it has to do this by collaborating. Dr. Daniel Cole, president of the APSF, sends his warm wishes to the Indian College of Anesthesiologists and would be eager to form a partnership, and the APSF would be honored, as he says, to be a part of an enduring relationship with the ICA, and it would be an honor to work with the colleagues in India for developing the shared vision that no anesthesia should be harmed by, no person during anesthesia should be harmed by anesthesia care. The APSF has had a significant impact on patient safety. It ensures that there's a culture of safety, there's teamwork, and the clinician safety is brought about by ensuring that there is medication safety, there is care for patients when they're given anesthesia in non-OR locations, methods to decrease infectious disease during anesthesia care, taking care of patients, their perioperative brain health, adopting modern airway care issues, and in the United States, currently focusing on the extensive opioid-related harm that has been experienced. APSF is trying to bring about a global influence and recognition of these efforts so that its actions can be well recognized by agencies throughout the world. The key activities of APSF are, besides education and training, is to obtain research funding so that programs that are helpful for ensuring patient safety can be carried out. It does bring out publications. There's a newsletter that you can access through its website. It has numerous global collaborations, not only with different societies, but also with industry. And its goal is patient safety initiatives, and it does conduct annual meetings and conferences, and is an active part at the American Society of Anesthesiology's annual meetings. It sets up guidelines and best practices for the care given to our patients. It helps with simulation training, and also provides many continuation education opportunities. Like I said, there is an APSF newsletter that is available on its website. There are numerous articles that one can find there, the results of research findings, and anything news related that is urgent will be placed on the website. We had many such alerts during the COVID era, during the COVID years, and it does bring out about updates on patient safety. It has many collaborations, so it partners with medical societies, regulatory bodies, healthcare organizations, and has been the voice and advocacy for safety standards and policies. It does get into action by having campaigns to reduce medication errors, also updates on improved airway management and enhanced safety for anesthesia equipments, and also monitoring that's used during anesthesia care. Now, I'm sure many of you are aware of Dr. Robert Stolting. He was a great anesthesiologist and mentor for many people. He was a leader in the APSF for many years, and to honor him, a conference has been established called the Stolting APSF Conference, and this conference is a platform for sharing knowledge and strategy development, and provides an opportunity for networking and collaboration. In 2022, the APSF conference focused on crucial patient safety issues related to office-based and non-operating room anesthesia. As you know, office-based anesthesia is practiced in many places throughout the world, and APSF ensures that safe practices are taking place in those locations. It's not easy to provide complete anesthesia care in a safe manner when you're not in an operating room location. So efforts have to be taken to make sure that there is patient safety in these locations. In 2023, the Stolting Conference focused on emerging medical technologies, a patient safety perspective on wearables, big data, and remote care. The key focus areas being the continuous patient monitoring and the application of artificial intelligence in improved patient care and outcomes. It was well received. The keynote highlights were potential of these new technologies to improve patient outcomes and the need for rigorous clinical trials and implementation of science based on the results obtained. The meeting summary can be found at the APSF website. APSF also brings out numerous videos that one can use. One is the prevention of surgical fires, a beautiful presentation that you can obtain by going to the APSF website. APSF does have collaborations with many countries, like I told you, and they've had national and international meetings in Malaysia in 2023, in Japan in 2024 this year, and Malaysia again in 2025. The meeting in Malaysia in 2023 was the first ever anesthesia patient safety symposium in that country, and this was virtual because of the recent COVID pandemic, and over 1,000 attendees from 48 countries attended, and they were spreading patient safety education, handoff communication, goal-directed therapy, and developing practical protocols for massive transfusion and hemorrhage. In 2024, the Japan conference focused on on international, it was called ICAPS, and they had keynote speeches on patient safety, collaborative relationships between APSF and anesthesiologists, and a history and future of the patient safety, including medical accident reporting. And it was collaborated with not only Japanese societies, but also by the ASA and APSF. So for ICA, a good proposal would be to work and collaborate with APSF, establish an Indian equivalent of APSF, and focus on patient safety in anesthesia within India. The goal being that there would be benefits, and such benefits would be enhanced patient safety, access to global best practices, increased research opportunities, hopefully by collaborating with international organizations. This can be conducted by forming a working group, identifying key focus areas, developing partnerships, and hopefully securing funding and resources to carry out the main goal of improving patient safety. Now, the call to action for the Indian College would be to summarize the importance of patient safety during anesthesia care, encourage Indian College to take the lead role in establishing a patient safety foundation, and the call to action would be to work together to make anesthesia safer for all patients. The next conference of APSF, the Stolting Conference, Dr. Daniel Cole requested me to inform all members and executives of ICA to attend this conference if possible. It's being held on September 4th and 5th at Boston. This will be the 40th year anniversary celebration of APSF. Now, I would like to say a few words about quality implementation during anesthesia care, quality QI. How is that conducted? Now, QI is very important during anesthesia care because the benefits are that it will enhance patient safety by identifying and mitigating potential risks and complications associated with anesthesia. The goal being to improve overall clinical outcomes and continuously refine anesthesia practices, with the final goal being to reduce morbidity and mortality rates. And the other thing would be how one can ensure efficient use of resources and minimize waste and reduce costs. This can be done by boosting patient satisfaction, by providing high quality anesthesia care, improving patient experiences and satisfaction, and fostering trust and confidence in healthcare when we provide anesthesia to our patients. Now, as you all know, this can be done by the systematic use of data and evidence-based methodologies to enhance the quality and safety of patient care. And for this quality improvement, continuous efforts are needed to make these incremental improvements in healthcare processes. We need to have data so that we can make the change and improve patient satisfaction. So the main objectives of quality improvement are to try to reduce variability in anesthesia care by standardizing anesthesia procedures and protocols to reduce variability in care, ensuring consistent high-quality outcomes, enhancing training and education by providing ongoing education and training to anesthesia providers to stay current with best practices and new technologies. And you have been doing this actually by having those webinars on a weekly basis, implement evidence-based practices into anesthesia care, monitor and evaluate performances by using data and metrics to monitor these performances and identifying areas that might need improvement, and evaluate the impact of the new initiatives that one might bring about. And the ultimate goal is to make sure that we have a culture of safety and that patients feel comfortable and have a very satisfactory outcome. So the final conclusion would be to enhance this safety would be to use the help of APSF in advancing our safety and clinical outcomes, and there is a critical need to improving anesthesia safety throughout the QI initiatives. An example could be looking at body temperature and seeing how we are taking care of patients intraoperatively by looking at their core temperature when they arrive to the PACU. Another would be to ensure that patients are completely reversed of neuromuscular blockers by using quantitative data and the appropriate pharmacological use of neuromuscular blocker use and reversal. The ICA leadership can jump on this opportunity because it's the right time for Indian College of Anesthesiologists to take a leadership role in establishing a patient safety foundation similar to the one of APSF, and then set these QI initiatives to standardize procedures, reduce risks, and improve patient outcomes. This can be done by, like I said, with good collaboration with APSF and also fostering international partnerships to share knowledge, strategies, and innovation in patient safety. So I call the Indian College of Anesthesiologists, call upon them to take this action and set up an India APSF. Thank you.
Thank you, Dr. Kumar Belani, for presenting to us on anesthesia patient safety, the safety foundation working elsewhere, as well as what is required for quality improvement. Now I bring Dr. Muralidhar Kanchi. Dr. Kanchi is a professor and head of the Department of Cardiac Anesthesia at Narayan Hrudayalaya, Bangalore. He is an accomplished anesthesiologist, and he is our national dean. And he is pioneering conduct of short-term courses in anesthesia. And our courses are accepted in the country as well as outside. And he is going to speak about standards of monitoring during anesthesia and recovery. He may touch upon what we had 30 years back, now where are we, and how we going to improve our monitoring parameters, and where we going to be at the end of this particular decade. Over to you, Dr. Murali.
My dear colleagues, respected leadership of ICA, and ladies and gentlemen, thank you very much for this opportunity. I'm extremely delighted and grateful to be with you this evening to spend a few minutes of your precious time talking about standards of monitoring during anesthesia and recovery. Anesthesia-related deaths are very rare nowadays, with a death rate of about 1 in 200,000 patients. Please note this. This was about 2 in 10,000 patients about 40 years ago. Now the anesthesia-related deaths have decreased over time due to improved training of the personnel involved in providing anesthetic care, technological and medication advancements. We have safer drugs, and most important is the monitoring, safety standards and monitoring, which have been in force in the last couple of decades. There are, however, some factors that can increase the risk of death. For example, medical conditions of the patients. For example, we have patients with severe comorbidities presenting for cardiac or any other types of surgery. And we have more aging population coming for surgical procedures. These are the factors which increase the risk of mortality and morbidity. And human error is inevitable. And there is a widespread recognition that human factors and ergonomics are key to safe delivery of healthcare. So, if you look at the history of anesthesia, On 16th October 1846, the first public demonstration of ether anesthesia took place. And from then onwards, anesthesia has been practiced more or less on a regular basis. And for over a century, the visual monitoring of the respiration, clinical appearance of the patient, finger on the pulse, and non-invasive blood pressure were the only techniques that were used. And in a publication which was published in 1978, these were the preventable anesthesia mishaps, and top in the list is the breathing circuit disconnection, which highlights that the monitoring of the respiratory system forms a major component of our care of these patients. And just then, it was reported that anesthesia was 1,000 times more dangerous than flying in an airplane 30,000 feet in the air. Please imagine this, but it is no longer so. And the credit of suggesting the imposition or practice of safety standard goes to Perry Jr., who in mid-80s proposed that we should have monitoring standards. And then this was approved by the American Society of Anesthesiologists in a delegation in 1986. And it was amended in the years which are mentioned in the slide. And there are 11 points mentioned here: adequate supervision, minimum monitoring of ECG with ECG, SpO2, NIBP, capnography. Even in regional anesthesia, procedural sedation, transfer of patients, this monitoring is indicated. Neuromuscular monitoring should be used whenever neuromuscular blocking drugs are administered. The PIS monitor was mentioned in the first talk, and monitoring of the blood glucose and ketone bodies are necessary in patients who are diabetes, especially when they're undergoing long-lasting surgeries. Alarm limits must be set on the equipment which you use, especially the monitoring equipment, and absolutely no doubt that we should maintain a impeccable anesthetic record. And additional equipment and monitoring may be needed in specific types of surgery. For example, in cardiac surgery, we need to have blood gases, blood sugars, electrolytes, and temperature monitoring, etc., done on a regular basis. The first standard which is mentioned is the adequate supervision requires that anesthesiology should be present throughout the conduct of the anesthesia or the administration of procedural sedation. And the general anesthesia requires minimum monitoring of ECG, that's electrocardiography, SpO2, non-invasive blood pressure, and capnography, which should be checked for correct function and begun before the induction of anesthesia and must be continued throughout the anesthetic management, transfer to the post-anesthesia care unit, and recovery. Age-adjusted minimum alveolar concentration should be monitored during the use of inhaled anesthetic drugs. Capnography is mandatory, especially if an artificial airway is used, till the patient is extubated and a response to verbal contact is established. The conduct of regional anesthesia should have the similar monitoring technique, whatever is used for general anesthesia, and patient should, if the patient is conscious and communicating effectively, no sedation is used, then the care may be provided by the anesthetic assistant. The procedure sedation requires minimum monitoring of SpO2, ECG, and non-invasive blood pressure. And the transfer of patient from the operating room to the post-anesthetic recovery unit or recovery area or the ICU, whatever may be the case, they should have minimum monitoring of ECG, SpO2, and NIBP. Qualitative neuromuscular blocking is used or indicated whenever neuromuscular blocking drugs are administered throughout all phases of anesthesia, from initiation of neuromuscular blockade until the recovery of Prana-4 ratio to be greater than 0.9 is mandatory. Processed electroencephalography, that is EEG, should be used when total intravenous anesthesia is administered together with a neuromuscular block. It should start before the induction and continue at least until full recovery from the effects of neuromuscular blockade has been confirmed. It should be considered during other anesthetic techniques, including inhalation anesthesia and for high-risk patients. I particularly like to use the BIS monitor in patients who have poor LV function because I could titrate the dose of anesthesia agents and avoid control the use of inhaled anesthetic agents. Blood glucose monitoring and checking for ketone bodies is mandatory in diabetic patients. And I am a fan of using the alarms. I always use the alarms and recommend the use of alarms on the monitors and set the alarms for each particular patient before the surgery starts. And it should be patient specific values, and the alarm should be audible, and the alarms, when it sounds, it should never be neglected. We should check what is the reason for the alarm and try to sort out the issue and then keep the alarms on. Maintenance of anesthetic record is a major or important aspect of care of patient. Anesthetic record should be made with an accurate summary of information provided by all monitoring devices. Automated electronic anesthetic system can be integrated into the hospital's electronic health record system. Additional equipment and monitoring that anesthetists should have include blood gas analysis, measurement of hemoglobin, and availability of bronchial blockers or flexible bronchoscopy, etc., as applicable for any given particular situation. In hospitals employing anesthesia associates, for example, physician assistants or nurse anesthesiologists, the responsibility to remain with the patient may be delegated to these associates, supervised by consultant under the scope of the practice of these personnel. And in emergencies, in exceptional circumstances, the anesthesiologist may be called to attend a life-saving procedure in a nearby theater or ICU. He or she might delegate the responsibility to the junior or the personnel present, the nurse who is capable and may leave the patient for a brief period. This is a matter of individual judgment, taking care of the patient's safety at hand. Fatigue and vigilance is an important component. And in patients on cardiopulmonary bypass, it is my practice to have anesthesiologists present during the whole of the bypass, not only to look into the physiological condition of the patient, but also to see that there's proper communication with the personnel present in the operating room, especially in terms of maintenance of activated coagulation time, the management of the mean arterial pressure, the electrolytes, blood sugar management, and weaning of bypass includes the checklist, which includes a patient being warmed at 6.5 degrees centigrade temperature, acid-base status being maintained, that gas are satisfactory, the ventilation is switched on, the inotropes and the vasodilators are available as and when needed. We should be able to initiate that one. Pacing box is available, etc. All this is checked by the anesthesiologist. So I personally see that somebody is present there. Just because patient is on cardiopulmonary bypass, one may not relax and leave the operating room. This is not to be done. Anesthetic report I already mentioned. In all cases, the monitoring devices which are necessary: pulse oximeter with plethysmography, NIBP, temperature, especially if the surgery is going to last for about an hour or so, 1 hour or greater than 1 hour. During general anesthesia, inspired and expired oxygen, waveform capnography, and depending on the technique, inspired nitrous oxygen or nitrous oxide concentration, inhaled end-tidal inhalation anesthetic drug concentration, airway pressure, tidal volume, respiratory rate, if you are using mechanical ventilation, quantitative neuromuscular blockade during all phases of anesthesia, especially when neuromuscular blocking drugs are used. EEG, glucose monitoring in diabetic patients, and during procedural sedation, whenever there is loss of response to verbal contact, add waveform capnography. In addition, we need to have infusion devices, cough pressure monitoring devices, capnography already mentioned, cardiovascular monitors as applicable to a given patient, and monitoring during as per already mentioned, and special considerations to be given in patients in locations outside the operating room and in MRI suites. With that, I would like to announce or highlight that next month we are having an international workshop come CME. This is being conducted in association with the Indian College of Anesthesiologists at Bangalore. Dates are 21st to 24th of August. Please join us. And I also would like to highlight that we conduct critical care echocardiography fellowship programs under the auspices of Indian College of Anesthesiologists, running successfully. And with that, I would like to thank you. And if there are any questions or comments, please feel free to do so. And thank you once again.
Thank you, Muralidhar, for highlighting on the monitoring requirements which we need in the future, which has to be stabilized now, as well as what we can hope for in the next 5-7 years. I request Baljit Singh to come out. Dr. Baljit Singh is a well-known man, well-knowledge and erudite personality. And he worked as professor head of the department at GVP and later in a corporate hospital, corporate college, in Delhi. And he's a thorough gentleman. And he's going to discuss on ethics. Well, wanting what you want in your path to go up. And after that, Baljit is in the process of designing certain methods to implement an examination system for Indian College of Anesthesiologists in India. And I am sure within a year's time, that also will show light. I request Baljit to take over.
Thank you so much, sir, for your kind words. And first of all, greetings to you all friends in India and overseas, particularly to Dr. Kumar Belani. It must be very early morning there that he is attending this webinar. Let me see my slides. Yes. If we look up the dictionary to understand what ethics means, it means pertaining to or dealing with morals or the principles of morality, pertaining to right and wrong in conduct, or being in accordance with the rules or standards for right conduct or practice, especially the standards of a profession. The aims of ethics are viewed in different ways. One is the discernment of the right from the wrong, and from good and bad. And ethics purports to devise the principles by means of which conducting a life worth to be lived. Why do we need to study ethics? There are three important reasons. One is it can help you to appreciate ethical problems, in whatever you do. It may help in long-term success of the objectives, and it is often correlated with behaving legally. So are the ethics and moral the same? If we look up the dictionary again, to which for these, the key difference, however, although the dictionary says by and large the same, the key difference, however, is that ethics concern rules from an external source or a social system, like a medical code of conduct for medical professionals anywhere, And morals are based on own principles around right and wrong, like principles of habits related to right and wrong that we, impose on ourselves. Are ethics important in life? Yes, they play a very crucial role in shaping the way people interact with each other. Ethics are the moral principles that guide people's behavior, decisions, and actions. And these principles are based on the concepts of right and wrong, good and bad, fairness, and justice. The conduct of a registered medical graduate is governed by ethics and regulations pronounced by the Indian Medical Council Act 1956. It had undergone some revisions in 2002, and the Indian Society of Anesthesiologists also has recommended similar guidelines for ethical practice in the field of anesthesia. Now, the basic principles of medical ethics are four. One, non-maleficence, that is to abide by the doctrine of primum non nocere. It is to do no harm. Whatever you do to the patient should not get any harm for the patient care that you're providing to him. Next is autonomy. It allows the patient to make informed decisions. Coercion is unethical. The third is justice, fairness in providing service to the surgical patients, all patients, and beneficence, to do good for the patient in every situation, whatever it is. There are certain ethical dilemmas in anesthesia. One, the patient is unaware of the role the anesthesiologist is playing in his patient care. Because when the patient comes to us, by and large in the OT, we put him to sleep. When he wakes up, we send him off. He doesn't know what has gone during this period. The patient may have some underlying disease. He may have very low ejection fraction, and even if he's coming for hernia surgery, this is a patient which is a difficult one for the anesthesiologist. Then the use of machines and gadgets in patient care that we use, poor recognition for the hard work done. Well, yes, I think we all can acknowledge that, yes, we are backstage people, and the patient and the public at large doesn't really know what precisely is our role and how significant it is. It may, over a period of time, may result in dehumanization of the patient care and the limited work done to incorporate education. There are not many things of this kind in the curriculum, and ethical issues can be pre, intra, and post-operative period. In the pre-anesthetic period, what's important is to keep patients' medical and personal information confidential. It is not to be shared. Any information about the patient's disease or his life is not to be revealed to anyone. And anesthesiologists should provide pre-anesthetic evaluation care and should personally provide this care as promised to them, and participate in the process of informed decision-making, especially regarding the choice of anesthetic technique. The preoperative issues concern the anesthetist and the patient less familiar with each other. Effective communication is necessary to establish rapport and the comfort level with the patient, and know how much to explain to the patient about the anesthetic process in order to get the informed consent from the patient. However, this may contradict, the approach of the surgeon sometimes, because surgeon may not really approve the anesthetist explaining all the risks, because he is worried that in case all the risks are known to the patient, he may go away. He may go to some other hospital. Patient may sometimes be very unethical, but it has been reported often in press or media or whatever, that patient may be posted for an unинdicated surgery. Fitness given by a physician, patient comes to the hospital, surgeon, tells that yes, the patient has already been given the fitness, so why don't you take it up? So there are a lot of pressures at times in the OT. And these ethical dilemmas can be solved by skillful interaction with patients, surgeons, and other colleagues without having a conflict. Intraoperatively, it's important to be compassionate in the operating room. The captain of the ship concept can create conflict. The surgeons usually think that they are the captain of the ship. Well, we have no problems with any such thing, and we don't that kind of policy. And on the other side, it is also said that surgeon is the captain of the ship, which is smooth sailing, but the captain of the ship actually is an anesthesiologist when the patient is in trouble. The surgeons usually do not come into that kind of care. So be diplomatic, avoid flashpoints during this period because this is significant. This is a very, very crucial period for the anesthesiologist and for the surgeon too. Calm and quiet nature may be misinterpreted as being docile. One should be polite but assertive and avoid domination during patient care. In the postoperative period, the anesthesiologist is the postoperative physician. Greater responsibility in the postoperative period until the patient is discharged should be exercised. And anesthesiologist may rely on the surgeon for postoperative pain relief sometimes because particularly those cases, those setups where the surgeon, where the anesthesiologist is coming for a short period of time, so he can leave the pain management to the surgeon. Ethical implications as inadequate pain relief is a common complaint because pain relief is something which the patient always has a long memory that yes, during that surgery, I had very, very severe pain and he will never forget that. Now, teaching ethics in anesthesia, yes, it's important. The traditional approach, however, is that learning through the examples which are set by the senior colleagues, you observe them, you see how they are interacting with the patient and how they perform procedures. Problem-based learning is an effective tool in teaching ethical values. You give problems to the patient, have their opinions, discuss with them, and then come out to a conclusion. Incorporating ethical issues raises awareness among the students and interprofessional relationships, obtaining consent, informing critical conditions to relatives, etc., are best taught using case scenarios and communication skill modules. If the student is given a critical situation, that needs to be explained to the patient's relatives for obtaining consent for something which initially was not scheduled to be. And here, a very skillful person with a good communication skill can have this consent comfortably from the patient's attendants rather than, ending up in problems later on. The role of consent is very important. Every human has a right to decide what shall be done with his body. And written consent is a must before any procedure, diagnostic or therapeutic, anesthesia, surgical procedure, or any even intimate examination of the patient. Informed written consent, it includes a proper discussion between the physician and the patient about all relevant aspects of proposed treatment and its alternative procedures, if available. And as per the Indian Penal Code, there are 5 essential components of an informed consent. I'll just go briefly into that. One is disclosure. Transmission of proper information that is relevant in decision-making must be disclosed to the patient with regard to the nature of disease, the options available for treatment, success and failure rate, and the cost of the treatment. Second is comprehension. The informed consent must be very comprehensive. It should be explained to the patients in his own language. If there is a language mismatch, interpreters should be used. And in case if the patient is deaf, dumb, or blind, special attention must be paid to these patients to ensure that the information required to be conveyed to the patient has been done and the patient has understood everything properly. There should be absence of any outside control. The informed consent should be given by the patient's free will without any undue pressure or influence from doctor, nurse, or any relative. Competence consent for the purpose of clinical examination, diagnosis, and treatment can be given by any person who is conscious, mentally sane, and above 18 weeks of age. Fifth is actual consent. To make it actual and legally acceptable, consent, everything must be in writing. Presence of 2 witnesses to avoid disputes over legal admissibility of the consent. Mention the name, the relationship of the patient whenever consent is taken. And if the patient is illiterate, use thumb impression and under the thumb mention his name and consent should be for a specific procedure. If any other procedure is required, well, this further consent should be obtained from the patient, and if the patient is under anesthesia, well, the patient's next, responsible person should be informed about the change in the procedure that is required, or the new addition to the procedure is required. Conflicts do occur. Commonly, it is the end product of clash of values, and I think that's what should be prevented at all costs, and ethics should be observed, whatever way it is possible. We come to research. Both are very long topics, so I'm trying to concise them within the time allotted. Research is a detailed and careful study of something to find out more information about it. This is a kind of dictionary meaning again, and process. It is a process of acquiring new knowledge and systematic approach involving diligent planning and interventions for discovery or interpretation of the newly gained information. Objectives of the research are to gain familiarity with a phenomenon or to achieve new insights into it, that is exploratory or formative research, and to portray accurately the characteristics of a particular individual situation or a group, that is descriptive research, and to determine the frequency with which something occurs or with which it is associated with something else, that is diagnostic research, and to test a hypothesis of a causal relationship between variables, that is hypothesis testing research. Well, the validity of the research depends on well-designed study with clearly defined objectives, which are, and it should be reliable, repeatable methodology. If somebody else likes to do the research, with the same methods, it should be possible for him. Appropriate conduct of conducting the research, obtaining the data analysis, and driving conclusions should be there. Inappropriate or faulty methodology would make study unacceptable and may even provide clinicians with faulty information. That's rather dangerous, because in case the information is not based on evidence-based and it is wrong, the patient care, of course, is going to suffer. Hence, the understanding of the basic aspects of methodology is essential. Methods of research, it's a narrative review based on existing literature search and literature research to know what is known and what needs further to be explored, and the various search engines which are available for information to be sifted through. PubMed, Medline, Google Scholar, Cochrane, and many others also. And to conduct the research, there should be some sort of methodology. There are 6 steps in the process of research. One is identifying a research problem, what exactly you want to know more about that. Reviewing the literature to see what is known and who all have worked on that and what are their conclusions. And specifying a purpose for research, you define a purpose, and then you conduct research, collect the data, analyze and interpret, and then reporting and evaluating the research. To identify a research problem, literature search from various research engines, form a research question, and define the aims and objectives of your study. The lacunae in existing knowledge would help formulate a research question, and this would help formulate a hypothesis, which is scientifically derived statement about a particular problem in the defined population. Study population and patient selection. Population refers to an aggregate of individuals, things, cases, etc. that are of interest and remain the focus of investigation. And in clinical practice, sampling is restricted to a particular place or multiple centers. Study period again needs to be disclosed, as it would help the reader to understand the relevance of the study in the context of time. Size of the sample should be predetermined, analytically approached, and sufficiently large to represent the population in general. And the attrition of patients should be attended during the sample size calculation also. Study design. The appropriate study design is essential for the intervention outcome in terms of its best possible and most reliable estimate, and the design may be broadly classified into quantitative and qualitative. Selection of controls is required because the disease may be self-remitting. There is a Hawthorne effect, which is change in the response or behavior of subjects when included in the study. And placebo effect, well, the patient feels improvement even with the placebo. Without any medical treatment, the patient feels a difference. Study tools such as measurement scales, questionnaires, and scoring systems need to be specified with an objective definition, and these tools should be validated before their use, and appropriate use by the research staff is made to avoid any bias. Then there is inclusion and exclusion criteria. This is to ensure that there is a homogeneous patient population that's been selected, and inclusion and exclusion criteria define who can be included or not included in the sample size. The exclusion criteria include factors or characteristics that make the recruited population ineligible for the study. And for example, patients with liver disease would be excluded if coagulation parameters would impact the outcome. The variables which are the definite characteristics or the parameters that are being studied, and these should be measurable and interpretable, sensitive to the objective of the study, and clinically relevant. Randomization or the random allocation is a method to allocate individuals to one of the study groups. It's not by bias that, some particular type of patients in group 1 and the others in group 2. The randomization should be very, very honest. And blinding ensures the group to which the study subjects are assigned not known or easily ascertained by those who are masked. It confirms that the intervention and standards of placebo treatment appear the same. Blinding is a different form of allocation, concealment. Blinding can be single blind. One of the participants, investigators or evaluators remain masked, and double blind, the investigator and participants, they remain masked, both of them. And to conclude, I would say that the basic understanding of the methodology is very, very essential to have a reliable, repeatable, and clinically acceptable outcome. The study plan, including all its components, need to be designed before the start of the study, and the study protocol should be strictly adhered to during the conduct of the study. Thank you so much for your patient hearing. Over to you, sir.
Thank you, Baljit, for detailing very well on ethics, morals, and on research methodologies possible.
Thank you, sir.
Now I call upon Dr. Jayashree Sood. Dr. Jayashree is a professor and head of the department at the most illustrious healthcare factory of India called Sir Ganganath Hospital, New Delhi. She is Associate Director of Administration at the service. And more than anything, she is the current President of Indian College of Anesthesiologists. And you are really seeing all the new developments which are coming up in the Indian College. And thanks to Dr. Jayashree, everything is taking a shape. And took some years for us to develop that particular level. Now, Dr. Jayashree will be talking on the point of care investigations. What is a point of care investigation? Over to you, Dr. Jayashree.
Thank you very much. Good evening, everybody. Thanks a lot, Dr. Radhakrishnan, for those kind words. At the outset, I'll bring my best wishes for the 4th annual webinar that we are presenting today. So good evening, everybody. Coming to my topic, which is the point of care testing. As we all know, this term we know very well, but because we've been using this term in the OTs, in the intensive cares, in the hospital for a very long time. However, when we talk about the point of care testing for universal healthcare, it's very important to remember, yes, it is the medical diagnostic testing performed at or near the site of patient care, which could be the hospital, which could be the home, or which could be anywhere in the periphery. So that's very important to remember. Of course, it's a diagnostic test that is performed. No, it's not moving. Sanish, this is not moving for some reason.
Ma'am, just try the rightward arrow in the lower down part.
Okay, right. So if you see this very simple diagram, they have depicted what is the difference between a POCT, which is the point of care tests, and the conventional technologies. Very nicely depicted. We know the conventional is very well established for since years. It's very reliable. It's very sensitive. But however, it is time consuming and it has multiple steps and can get complicated. Whereas when we talk about the point of care technology or the tests, they are freely available, very fast, simple. But remember, of course, they have low sensitivity and low reliability as compared to the conventional tests. Here again, the same diagram is depicted, in which above you see the conventional testing that we do normally in a hospital. The patient comes, the sample is taken, it goes to the lab, and then ultimately to the doctor who analyzes it, and then the patient's treatment starts. Whereas in the point of care testing that we do is that the sample is taken right there where the patient is situated, analysis is fast, interpretation is done, and treatment started right away. So that's important, and therefore point of care testing for universal healthcare is very, very important. Now, this again features, if you see, yes, the point of care testing is efficient. It's a more efficient workflow process. Speed is fast. Therefore, the decision making is fast, treatment fast, and it is possible at a variety of sites, whether it's in rural areas, disaster zones, anywhere, places where the patients are inaccessible or the places are inaccessible. What about stability and handling? Because there is a very small amount of the fluid, whatever sample is taken, and it is sampled right away, there's very reduced possibility of sample deterioration because it doesn't have to travel at all. And plus, because of the reduced volume required from these equipment, naturally the loss is less. So any patient who requires frequent testing like a blood sampling frequently naturally benefits from this. And of course, we said there's no transportation, and because of this, especially these point of care technology, these tests are made, the instruments and the equipment are portable. So this has a short turnaround time, which leads to a short waiting time, and we said rapid decision making and improved patient outcome. Whereas the point of care is flexible, done anywhere, right from the pre-hospital, which could be the emergency, field hospital, disasters, and of course in the hospital as well, which is the emergency department, ICU, and even in the wards. So which are just to tell you a few examples, which are done as a point of care test. All the various body fluid tests can be done, starting right from blood glucose, blood gases, the CBC, the pro-BNP electrolytes. Whereas coming to the equipment or the physical test, top of the list is POCUS, which we know is nowadays the latest, and as was told that the point of care ultrasound is now going to replace the stethoscope of the doctor. Other ones like pulse ox, portable X-rays, ECG, and portable monitors are also available. But yes, it is costly because the implementation of a test, of a point of care test, initially is of course expensive. And then later on, of course, because each patient requires one test to be used, and that sample is lost and is thrown away. So that is the reason the reagents are used separately, and therefore ultimately the cost becomes high. You require a good training staff. That's because you might be having the staff posted in different places far off, and the staff may be so many. So training of the staff is so essential. You might get false positive or false negative results, and this also requires a proper documentation. Now, this is the term assured criteria. This was used by the WHO in 2003, and this actually, the word was coined as an acronym which described the ideal test to meet the needs of the developing world. As you can see, the term assured is affordable, sensitive, specific, user-friendly, robust and rapid, equipment-free, and easily delivered to those who need the test. So these were the assured criteria to ensure that the equipment that you are going to use for the point of care testing should have these assured things to be present. But interestingly, we have this word assured by the WHO, but then to improve the future diagnostics, because again, ensuring assured has its own problems. So this was now that the word is recoined or rephrased as reassured, in which RE has been added. And this is mainly because to improve the real-time quality control. And if you see here, the RE that is added to the assured to make it reassured, here this stands for real-time connectivity, which is the tests are connected to any smartphone or mobile phone so that they are easily accessible to anyone, anywhere. And second is the ease of specimen collection. And they say that try and use non-invasive specimens for the tests. Now, this is a diagram just to depict how you can have this as a reassured way of ensuring that the focus can be done, the point of care testing can be done. And this, if you see, is the sample introduction. And after a while, once it is detected, immediately a printed communication takes place and there are printed electronics available. So this just shows how reassured can be done, can be practiced. But remember, this is very important that you have difficulties in this, where when you choose the method and instrument selection, validation, and installation is very important, where you must, the instrument that you are using must be very, very selectively selected. It should be validated and then installed, because continuous use, if not validated, will have problems. You must have an end user initial training. As I said earlier, that's very important, because if you don't have the training, and then it will be misused. And when I talk about the training, it's not only how to use the how to use the test, but also how to read the test, and then how to take the sample, and ultimately how you dispose of these samples. That's also very important. And also how you maintain the equipment. So this is a huge task for the trainees who actually are not really trained initially. User competency, which means they must know everything. Now, quality control is so important. Now, quality control, as you have heard in the earlier lectures, is important. And here too, it is very essential to keep up the standards. And if the quality control is not practiced, naturally, it will be a failure. The results will be absolutely wrong. But continuous quality control monitoring ensures that this is there. Patient monitoring, of course, should be there. And then re-accreditation also should be done. Now, there are emerging technologies and portabilities in which they say that now they're trying, after all, you have to have some emerging trends in the point of care testing. For everything, you need to have some evolving technologies. And here is to make it more and more compact, integrate with advanced technologies. That's very important. There's something known as the Internet of Things. That is, you connect it, you have some facility where your results can be connected by internet and received by any person. Artificial intelligence is coming up in a big way, and where we ensure, of course, it will help in the staff and others to read the results. Machine learning, of course, is another aspect which will help in emerging trends in the future of the POCs. And another thing is you have a wide range of tests on a single device. So if you have one device, It's not just only one test that you can do, that you could probably do many more tests on one single device. And then, as I said, enhanced connectivity and data management features. The other things, as we said again, single-use devices, disposable devices, but here they have to learn how to dispose them off so that the environmental integrity is maintained. Then you have the advancement in biosensors and bioanalytic techniques, development of smartphone-based POC testing devices, and integration of these point-of-care testing devices with electronic health records. So all these are the advances, and which of course are being done in the other countries, but possibly in our country and in other developing countries, these will gradually be merged. Now, of course, the benefits of these emerging trends will be enhancing patient care and treatment results. Naturally, this will help in that. Improve the efficiency and cost effectiveness in healthcare delivery. Expansion of the testing applications beyond traditional settings. And empowerment of healthcare professionals and patients with real-time data. But there are certain future challenges that are definitely there. And what are these challenges? That the regulatory considerations and standardizations have to be remembered. The privacy and security concerns in data transmission. So it's not that easy that you start some system and then we just continue with it. You have to ensure that this data transmission, etc., has to be very, very secure. Integration of the testing devices in existing healthcare system, and continued research and development in technology. So the steps to improve this, now coming to the insurance companies, everything you know these days is run by the insurance companies, and so also in the point of care testing, the insurance companies are playing a role. So here we have to improve this for insurance companies and for patients who have insurance. You have to ensure accuracy and reliability, or otherwise the insurance companies will not accept these tests. You must have training and certification, again, of the staff. Standard operating procedures must be present in which to ensure that each and every test has an SOP. Quality control and quality assurance, which goes a long way in many ways and now is an integral part of any healthcare facility. Documentation and record keeping becomes very, very important. Now, how can we again improve this for even the insurance companies? Integration with electronic health records, compliance with the regulatory standards. So whatever standards are there, you have to ensure that the point of care testing that you're doing should be compliant with that. Regular audits and reviews. Nothing can be effective unless you audit the results. And that is a very integral part, especially where the insurance companies are involved. Patient education and communication. They should be told about these things in advance, that whatever test you're going to do, is it valid by the insurance companies and how they should be communicated. Cost effectiveness, of course, each and everything that has to be done, they have to see whether the tests fall in the domain of the insurance company. So what are the other things? That the cost of the single-use test, what are the challenges that we are facing in this point-of-care testing? As I said, single-use test, the cost is increased. One patient, you can use only one reagent, the reagent that is present, whereas when you're using it in a laboratory, in a hospital, you get a huge container in which you have the reagents in large volume, and that can be used for several patients, but here it is not. So single-use tests, the cost is increased. The regulatory complexities and the standardizations help in overcoming the challenge of running these PO point-of-care tests. Documentation has to be compliant. You must make sure that things are documented and that this is done regularly by all the staff. Staff with limited training who performs must have a foundation training of each operator, And then assuring regular clinical updates for these people. It's not that you just treat them once and it finishes off. So assuring regular updates is important. Now, this is the Clinical Laboratory Improvement Amendments Act of 1988, the CLIA, which ensures that your tests that you are doing are up to the mark. So it regulates all the lab tests, including the point of care tests. And their guidelines mandate that you have specific personnel requirements, good lab practices, and if you fail to meet the minimum CLIA standards, it may lead to sanctions of the equipment. And they also have unannounced inspections where they come and see your area where you're performing these tests. Now, the role is this in acute care and health services. This is a recent published only this year. And what they have said that point of care testing has a crucial role in delivering urgent and appropriate health services. So now they have recognized that it is a very important role in disaster areas, emergency situations, peripheral communities. And it aids in triage and quick management decisions. So it is well documented that it is here to stay and improve. They have actually said that it should be the frontline investigation that should be done whenever a patient is in one of these areas. It can improve the quality of healthcare services and ensure provision of necessary healthcare. Now, what about risk management in these testing? Naturally, when you're doing these tests, the point of care tests, they're becoming so popular. Like we saw in the COVID pandemic, what happened was all these home tests were done. And because of this home testing and being testing for other things as well, like HIV, etc., what the increased popularity. Now, once you have increased popularity, naturally, the chances of errors are high. So here, how will you mitigate this risk that is possible by the use of this test is you improve the quality of test results and quality control plan. As I said, quality control plan was already CLIA, but in addition, they also have Clinical and Laboratory Standards Institute. So both these labs ensure that the quality and the standard of your testing is fine. Plus, you have individualized standards in which you can have your individual, how you can you can judge yourself how you are doing. So ultimately, to conclude, yes, the point of care testing improves healthcare services with a short turnaround time, flexibility, ensures that there is better patient outcome. Thank you very much. Thank you, Dr. Radhakrishnan.
Coming. Thank you, Dr. Jayashree, for highlighting on the point of care testing. It came to a practice during COVID times. And then only we realized that we may be able to get a precise testing done at the bedside of the patient, whether in home or in hospital. And the point of care testing is getting popular. Even though challenges are, it is going to be costly, as well as takes time. But it's a convenience and the comfort of a patient matters. And probably that is a motto of healthcare service in the future. So point of care testing is going to remain. And we are thankful to you to discuss in detail about the point of care testing. Thank you.
Thank you.
I'll be talking to you on Consumer Protection Act and how we anesthesiologists should approach to consumer protection. Well, friends, you know, nearly 300 million surgery going on in the world every year. This is, in fact, a 4 years old statistics. And out of the 300 million surgery going on, nearly 30 million are from India alone. probably it would have increased slightly beyond 330. Well, the present day studies, well, I don't know. But the reason for introducing the Consumer Protection Act in India is very simple. Because it was a national health directives or the National Health or Public Health Act, which was followed in the pre-independent times, continued on without much change for nearly 4 decades with the same directives. It turned into an act later. Same time, the government of India is introducing Indian Medical Council Act 1956, which was amended further in 64 and further amended as National Medical Commission Act in 2019. So these two things were there in the healthcare sector. And then comes Consumer Protection Act in 1986. The reason why Consumer Protection Act was brought in is that since there was no adjudicative process in the healthcare sector, all the healthcare complaints were heard in the civil courts, which the government wanted to change. And the government brought this also into the consumer protection. That means a consumer is going to complain about mismanagement or negligence or deficiency in service, where he going to put up his grievance. That grievance is going to be heard. And if compensation has to be given, compensation is given, as well as healthcare of the complainant is taken care of. And initially, we all had doubts that healthcare is not coming in the CPA and only other sort of services are coming in the Consumer Protection Act. But it was not so. The government clarified that healthcare also comes in, and their further modification of the Act in 1993, 96, as well as in 2016, brought that particular clarification very, very loud and clear. Now, people among us, even anesthesiologists, are a bit vague about the Consumer Protection Act and how far that is going to damage us. There are multiple acts which came along with it or after that, called the Clinical Establishment Act, as well as Medical Professionals Protection Act. But that is nothing to do with Consumer Protection Act. Consumer Protection Act stays alone, and that is where we are going to be tasked if we are going to end up with some sort of a negligence in our service, or if we are part of exhibiting a deficiency in the care provided. And the purpose, as I said, the government wanted the public's complaint to be heard outside a civil court, because in the civil court, it takes longer period of time and a quick disposal or a remedy is not at all offered. Whereas in the CPA court, a quicker remedy comes in most of the times. So the government has created district consumer forums, state consumer forums, as well as national consumer forums. It is all against medical negligence, whether by omission or by commission, as well as if a deficiency in service was given to the patient. Well, it's a long standing list when we say about the medical negligence or the deficiency service. Anything could be attributed that the patient was not getting adequate service, like awareness during anesthesia, or lack of monitoring, lack of PAC being done, or autonomy of the patient was not accepted, or patient was not told about the complications of that particular anesthesia procedure and surgery, or particular anesthesia procedure was shifted without patient's knowledge. So list is a long list. Anything can be added onto that. But who are all liable? Are we liable? Yes, we are all liable. Any paid service in healthcare is liable to be acted upon in the CPA. Any paid service means if the patient or the patient's relation or a third party is going to pay for the services which is rendered to a patient, well, that patient has justifiable claim to go to a consumer protection forum and complain against some service which was not up to his choice. That means if he is unhappy about the services given to him, or say the service was insufficient, well, the patient may be able to complain. And the patient could complain any time up to 2 years after the incident or after the event has occurred. And sometimes some court may condone the delay up to 5 years. And another one thing, complaint could be lodged from anywhere in India at any of the consumer forums. That means the patient is given the full liberty, patients or their relations, who are all the sufferers going to be given the full liberty to go up to 5 years to complain about an event which was unhappy to the patient, or patient had some deficiency in service and patient had to meet with some sort of alarming or non-alarming or catastrophic events. And we are all liable to be heard by the complaint, and the court is going to decide on that particular grievance after hearing both the parties and going to say who is at fault and what is the fault and how much is the compensation. But some of us may be thinking, if we are going to be hired as an anesthesiologist by a surgeon or a hospital, are we coming under the CPA? Unfortunately, we are. We are also coming in. That means we are all coming under CPA since we are giving our service to an institution and through the institution to a patient. So we are coming because that service is paid service. Even at charity hospitals, if the service is on a token payment, then also the CPA is going to act on them. That means whether charity hospital or say government hospital or corporate hospitals or any sort of private hospital, whatever it may be, where you are giving free service or you are giving paid service, well, CPA is going to punish you for negligence, which we are going to put on the patient, and we are going to give a service which is inferior, which patient has a grievance and patient is able to complain on it. And then what is our liability or our responsibility? Our responsibility is very simple. We should do no harm to the patient. We should be good to the patient, and patient's autonomy has to be respected, and we should be fair in our services. If we are going with that, I really doubt, well, we could be attacked under the CPA unless something gross has happened, probably to our knowledge, and may not be to our knowledge, something which is going to refer as deficiency in service later. And one thing which is coming up again is called a CPA and CCPA. This is going to be more dangerous. CPA, he said, well, you're going to be challenged in a court of law. This court of law or the CPA consumer court is almost similar to any civil court. Only thing that the formality there is more simple and the cases run fast. And well, the CCPA which is brought, that is called the Consumer Protection, Central Consumer Protection Authority. Central Consumer Protection Authority means it is something about the product liability. The product liability here, as far as anesthesiology is concerned, the particular product which we are looking at the end of the service, that means a spinal block is given, or a regional block is given, or an endotracheal tube is put in. Well, if something happens to that particular service, if that product which is supposed to have an assured ending, if going away from that, that means assured ending of that particular service, which is going to be away from what is being written in the textbook, is going to happen, we are going to be charged under product liability also. That means life is going to be slightly difficult for us with all these particular things. And one may be wondering, is there an escape provision? Unfortunately, this was a vague feeling in the very beginning. In 86, later in 96 also, people had thought that doctors will not be challenged. Unfortunately, the case against the government of India by VP Shamda / Jacob Matthew / the Union of India, that particular case came out and said healthcare comes under ambit of CPA, and if there is a negligent service, healthcare people all are involved. But we still had hope. We may be exempted. The reason is that the advocates in the country, they are exempted from Consumer Protection Act. Any advocate or every advocate practicing in Indian Union are exempt from Consumer Protection Act. We thought we may be able to get that particular convenience. But in 2019 amendment, that also was shut. Recently, there was a case going on at Maharashtra court telling all these particular things. And Medical Legal Society was challenging why it is given to advocates, why it cannot be extended to the healthcare practitioners. But the Supreme Court, under the leadership of Chief Justice, denied, telling that that cannot be given, and that also is closed. And now, well, we are summarily responsible for any deficiency or any sort of a negligence which happens during our procedure. Negligent actions, as I said, is an ongoing list. There is no end to all these things. And anything which is going to be uncomfortable to the patient, that can end up as a grievance. So the moral of the story is very simple, that we may have to settle a grievance which comes up against us at the earliest, and that too at the lowest court. Why I say earliest and the lowest is that sometimes we may have a thinking, if we don't turn up to the notice of the court for 3-4 times, the case is not going to be heard. That is a mistake. The case is going to be tried in your absence, and the verdict is going to come out in your absence. So even if you are not there, you can represent through your advocate, telling that I may be able to come next time when the court going to summon on me. So it is better we go to the court every time when the case is called up. And same time, we have to have parallel ground level negotiation taken up with the advocates as well as with the grieving party. So if possible, have an amicable settlement if you think you are at fault, and have that particular amicable settlement at the lowest level. Because the consumer court at the lowest level may be able to fine you up to 1 crore. And if it is going to be the state court, it's going to be up to 20 crore. And at the national level, beyond 20 crore. That means the sum offered as compensation or penalty is so high. So better we settle at the district level. And another thing what I would like to say, death on table. Death on table easily affects CPA. In death on table also, well, if you are rather ending up in such a circumstance, well, what you have to do hurriedly is that you complete the case sheet or case notes then and there. You call your friends there and ask them to have a relook into the particular case notes. If you have omitted some particular part, well, they may be able to fill it up. But before the death is declared, see that case sheet is completed and keep the area clean. Keep the area clean, I mean, saying not to sweep the floor and keep it clean. That means there should be no broken parts or no broken instruments. There should be no expired drugs in that particular scenario. And once that scenario is taken care of and the notes are written, you can declare the death to the patient in the most humble and simple words. See, something happened, we are not sure, we have tried our maximum, and the patient is rather escaping our hand. That means you have to break the news in with utmost discipline. We have to break and then inform the police. Once you have informed the police, you have less time to do anything further. And once the police comes over to the scene, they take over the scene. And well, let them take over. But you should not leave unless you insist on postmortem of the particular patient, as well as histopathological diagnosis of which area the surgery was being done. Or say you should have an histopathological diagnosis also for the particular patient. So these are the things which we have to remember about when we're going to be sued under CPA Act. I hope nothing will happen to most of us, but we should be careful because we had a very vague feeling that CPA is not at all going to charge us, but it is absolutely irrational. CPA can call on to us anytime, whether you are corporate sector or in the government sector or in the lowest primary health center. So I hope that nobody is going to be unlucky that way, and wish you all bright future and bright practice years ahead. And thank you all for hearing me. I request Dr. Jayashree to take over, tell about the postgraduate assembly which is going to take place in 2 days' time, as well as our annual at Lucknow and the vote of thanks.
Thank you very much, Dr. Radhakrishnan. Coming to the end, this comes to the end of our webinar. And thanks a lot. I'm sure there may be some questions that the audience might want to ask. So you could then email to any one of us and you would get the reply. We are very, very happy today to announce our 5th International and 15th National Conference of the Indian College of Anesthesiologists, which is going to be held in Lucknow this year. And this is going to be, is being organized by the King's Medical College, King George's Medical University. You are most welcome to attend this and do come. You can register online. And the workshop is on the 12th of September, whereas the conference is on the 13th to 15th. So please do make it. Another very important aspect that I would like to tell you is the yearbook of anesthesiology, which we release every year. And last year, the yearbook volume 13 was released. And this is all by the efforts of our editor, Dr. Mukul and Dr. Baljit. We are having the New Delhi PG Assembly next week. In fact, in the last day of this week, starting 27th July, and we are very, very proud of this. And actually, this is our first Indian College of Anesthesiology's New Delhi PG Assembly, in which all the hospitals of Delhi have pitched in, and they're all contributing in some way or the other. So this, we are very, very happy that we are doing this one. This was a dream long time back, and this is inculcated this time. So let's hope that we all do well. And the best part is that the registrations are closed. 150 registrations are there, and this would be a 5-day PG assembly with all the faculty, renowned faculty of Delhi, and of course, some cities nearby. So with this, I'd like to wish a very good night to all of you, and thank you, everyone. Thanks a lot and good night.
Attention, anesthesia residents. Get ready for an exciting opportunity to shape your future careers at ICA National Conference 24 in the vibrant city of Lucknow.
Hello everyone, I'm thrilled to announce the Postgraduate Career Orientation Program exclusively designed for anesthesia residents, happening at ICA CON 24.
This program features expert faculty from across the globe, offering you a unique chance for live interactions on various career opportunities overseas.
Explore the prospects within different subspecialties, gain insights into the current anesthesia curriculum, and learn about the diverse career paths available to you.
Attending the PG mentoring session at ICA conference was a game changer for me. The guidance and knowledge I gained helped me make informed decisions about my future.
Don't miss this incredible opportunity to network, learn, and advance your career in anesthesia.
Mark your calendars for ICA Conference 2024 in Lucknow.